Hello, this is Evaluating Pharmacist Provider Billing Opportunities, and my name is Carrie Trapskin. I work at the Pharmacy Society of Wisconsin as Senior Vice President of Practice Transformation. I'll be joined today by Abby Lindy, who works at the Community Pharmacy Enhanced Services Network, or CPESN, as well as Michelle Farrell, who is the owner of Basketball and Center Drugstores. We have no relevant financial relationships to disclose today, and our learning objectives are listed here on the slide. We would be remiss if we didn't mention that none of the three of us are official medical billing experts. However, we have worked with billing and coding experts to verify that this material is as accurate as possible, though changes in regulations, practice, or interpretations may occur. Medical billing is very complex, and we will all be learning along the way. We do advise consulting with your organization's experts for future guidance. So let's make sure we're all on the same page before we get started. Back in 2021, there was a bill that passed called Wisconsin Act 98, which requires Wisconsin Medicaid to pay pharmacists for any patient care service within the pharmacist's scope of practice or delegated to the pharmacist by a physician. Since the beginning of 2023, PSW has been actively engaged in helping to decipher, advocate, and educate on how pharmacists can take advantage of this very exciting practice change to be able to provide more access to needed services for Wisconsin Medicaid patients. It's very important to note that the collaborative practice agreements are a key component of Wisconsin Act 98. When Act 98 was passed, Wisconsin already had a broad scope of pharmacy practice since 2013 with Act 294. That's when the Practice Act was updated and allowed pharmacists the ability to accept delegation from physicians for services not in our scope of practice. That is the reason that PSW focused on advocating for expanded pharmacist reimbursement rather than scope in Wisconsin Act 98. So broadly, let's talk about what services Wisconsin Act 98 allows pharmacists to provide and be reimbursed for. We put this chart together at PSW to try to simplify what can be considered a fairly complex process. First, we start by asking ourselves, is the service currently covered by Medicaid's medical benefit for other providers? Wisconsin Act 98 doesn't actually add additional services to Medicaid's covered service list. It only adds pharmacists as providers that can provide services that are already covered by Medicaid. So if the answer is yes, then we need to ask whether the service is within the Wisconsin pharmacist's scope. It's important to remember that standard consultation covered by a dispensing fee is not considered something that would be eligible to be reimbursed for under the medical benefit. However, education on drugs, disease states, and devices is considered within the pharmacist's scope of practice. If the answer here is yes, that the service is within scope, then it may be billable to Medicaid unless the type of provider or place of service is limited. If the service is outside of scope, then a collaborative practice agreement or CPA with a physician will be needed. Something to note here is that to bill on the medical side, you do not always need to have a collaborative practice agreement. This is a point of confusion that we've been noting with questions we've been getting. The distinction between needing a collaborative practice agreement and not is typically when a prescription is needed to be written or labs are needed to be ordered. Those are types of things that would be physician duties and need to be delegated via a collaborative practice agreement to pharmacists. A big portion of what we're going to be talking about today is whether the Wisconsin Pharmacy Quality Collaborative Medication Therapy Management Program could or should be used in certain circumstances. In many cases, there's not one definitive answer, but the answer may depend on the specific situation. So listed on the slide here are the criteria that make a patient eligible for WPQC Comprehensive Medication Review and Assessment services. Another very important concept for us to understand is the difference between how WPQC versus provider status medical services are funded. Though both utilize the Forward Health portal to submit claims using CPT codes for reimbursement, the pots of money that pay for the services come from different sides of the Medicaid budget. Wisconsin Pharmacy Quality Collaborative WPQC claims are paid for through the prescription budget, which is carved out to be paid for by Forward Health, where provider status medical claims are paid for through the medical budget. Because of this difference, pharmacists need to contract with fee-for-service Medicaid, as well as individual HMOs in order to be paid through the medical benefit. So in a few slides, we're going to be jumping into discussing several cases. And we're going to be asking you to think about several things to help determine the best way to bill for specific services. So there's a couple ways to look at this using the information provided from slightly different perspectives. So I like to think about it as, can I provide the service? And what is the best way to bill the service that I already provided? If you are thinking about whether you can provide a specific service and bill for it, you're going to want to consider both whether the patient and pharmacist are eligible to provide the service, looking at the patient's conditions, whether you need a collaborative practice in place, whether the patient is covered by that specific collaborative practice agreement. Do you need to be privileged within your organization, etc. Also, you need to think about insurance coverage, whether the patient is covered, as well as whether the pharmacist and organization are contracted, accredited, or credentialed. Or if you're looking at this from the vantage point of I provided a service already, what's the best way for me to bill for it? First, you need to figure out whether you can bill, which is dependent on some of those similar criteria. And then the best way to bill. So we're going to talk about how you decipher that in a stepwise fashion using WPQC and medical billing as a provider. For completeness and point of clarification, when providing medical services, there are copays that patients have to pay. They are different from pharmacy copays. This is information from the Medicaid handbook online, topic 555. If you see in the columns, based on the amount that you bill using specific CPT codes and the amount in the max fee schedule, that amount determines how much in the right-hand column the patient is needing to pay for their copay for the visit. Couple more slides that I want to provide you just for some background information before we move into the first case. Wisconsin Medicaid, in terms of vaccination billing, continues to cover all ACIP vaccinations for adults under the prescription benefit. So any vaccination provided in the pharmacy for Badger Care, Medicaid, and senior care members is going to be billed under the prescription benefit. And then a reminder that pharmacy providers can administer any ACIP recommended vaccine without a prescription. You have the reference there. The administration reimbursement, approximately $15 per prescription or per vaccine, is bundled in the payment for each vaccination. So you do not need to, and you won't be able to, to submit the vaccine plus the vaccine administration code. In our state, we have all of that information bundled, all of that reimbursement bundled together. The patient is vaccine hesitant, you may consider billing Preventive Medicine Evaluation and Management Code 99401 if it's medically necessary. And something else that people are very interested in billing initially is the medical components of a non-vaccine injection. We had a previous session on non-vaccine injection, which did include a good portion of billing section. What you need to know right now is that there is the ability to bill for an administration fee as well as an E&M visit, as long as you have enough enough documentation to justify the medical necessity of the E&M visit portion. The way you submit the claim is going to depend on whether the patient is a fee-for-service Medicaid member or an HMO member, and whether you obtain the product and plan to bill the product through the pharmacy using the NDC or on the medical side using a J code. And last, point of care testing, another one that people are thinking of billing early. There's two components to the point of care testing. So testing or screening does not require a collaborative practice agreement, but testing and treating, test and treat, would require for the treatment portion a collaborative practice agreement. So if you're prescribing an antiviral for COVID or flu, you would need a collaborative practice agreement in place. You have to pay attention to whether products are CLIA monitored versus CLIA waived. And as we know, the waived products are the ones that would be the products that you would be able to utilize. You need to be registered as a CLIA waived pharmacy and need to become an independent lab in order to bill the test. There's more information at this link that's listed here. This will allow the pharmacy to use their NPI to bill for the actual test, but then the E&M office visit for the service and interpretation of the test could be billed under the medical side using the Pharmacist NPI. So let's jump into our case-based collaboration. We're going to be looking at comprehensive medication reviews through WPQC, evaluation and management office visits, as well as preventive medicine throughout the next several cases. So our first case is a comprehensive medication review and assessment service. Patient RX comes to the pharmacy to pick up one medication for hypertension, 2 asthma inhalers, and an SSRI for anxiety. RX seems nervous and confused. He was just in the ED over the weekend with an asthma exacerbation and is overwhelmed. Your technician notes that RX has a Forward Health card for prescription coverage. When asked, RX reports that the Medicaid plan they have for visiting the doctor for medical coverage is MHS. Your pharmacy is a WPQC accredited pharmacy and just officially got contracted for medical services with MHS. You also just got credentialed with MHS. RX asks whether you could help him understand his medications and make sure he's taking everything correctly. So I'm going to give you a couple of minutes to read the case, and then we'll be asking for some input while we work through the case together. So think about what types of things I've described so far that would help you decide what way and options you have to bill for the service that you're going to provide. So some things that we're going to be considering in terms of what our options are for billing. If we go down the WPQC route, we know that this patient has 3 conditions and 4 medications. They have hypertension, anxiety, and asthma, as well as 4 medications to treat those conditions. So we know that they would be eligible for WPQC, as well as medical billing, because we know that they've got an active HMO, the patient does, and that you are contracted with that HMO. And in this case, we don't need a collaborative practice agreement that we know of. So the case continues. You schedule an appointment with the patient for a medication checkup for the next day. The CMRA identifies the following items. The patient's albuterol refills have been increasing and their current steroid inhaler is BID. Their asthma control test reveals uncontrolled asthma. So you discuss the asthma action plan with the physician and the potential for transition to SMART, which is single maintenance and reliever therapy, which would be that formoterol and an inhaled corticosteroid, scheduled and PRN. And then you have the patient has a plan to follow up with the physician in 2 days. So you educate the patient on adherence to the antidepressant based on the patient feeling nauseated since having started it 3 weeks ago. And then you also provided a blood pressure check, and the blood pressure is normal today. So what are our options for billing? As I mentioned, we've got forward health coverage. We've got 4 meds, 3 conditions. So we're a good option for WPQC here. In terms of billing, you're WPQC accredited and certified. You can use the 99605 through 99607 CPT codes. If you recall, the CPT codes through Medicaid for on the prescription side of the benefit here pay a flat fee. So for an initial visit with a patient, you're going to receive $85. For a follow-up, you'll receive $40. You do need to call the DAPO center to get a prior authorization to provide this initial service plus 3 follow-ups. And then you'll need to submit the claim through the Forward Health portal or certified software. In terms of medical billing and making that case, this patient has a Medicaid HMO. You don't think you require a CPA at this point. You're contracted and credentialed. And then we would probably use evaluation and management codes in this case because we're dealing with problem-focused issues. For that, we're going to need to determine whether we use time versus medical decision making. That's the 2 different pathways we can go down with E&M codes. And you have a new patient here. For the time-based option under medical billing using evaluation and management codes, you spent about 50 minutes with the patient total. So that includes documentation and investigation. It's only you that you're only allowed to have the provider count the provider's time. We're going to go through the time-based billing on the next slide here. So in this case, because it was a 50-minute visit, we're just going to look at the left-hand column here, the level of we're going to look at the left-hand column here, and you see 45 to 59 minutes. So 50 minutes falls in this moderate level. So the 99204, the 99204 is the initial, and the second number here is if you have a an established patient. So in this case, we would be picking the 99204 code if we were to use time-based billing under the evaluation and management section. Now we're going to go through the option of medical billing using the medical decision-making route. Medical decision-making is made up of three different categories. So the number and complexity of problems addressed in the encounter, the amount or complexity of data to be reviewed, and then the risk of complications or morbidity and mortality. So in our case, we have asthma, and it's a chronic illness with progression. We have a side effect from anxiety treatment, and then a stable chronic illness. That puts us in the moderate category, and I'll show you that in a minute on the chart. Then the amount and complexity of data. We discussed the management of test interpretation of that asthma control test with the physician. So that also puts us at moderate. And then prescription management. We don't have a collaborative practice agreement, but in this case, we were spending a pretty significant amount of time making the recommendations with the physician, and with appropriate and adequate documentation, we feel pretty comfortable choosing RX management here. So you'll see that the number and complexity of problems addressed, as we mentioned, 1 or more chronic illnesses with exacerbation. All we need is 1 of these. So we're falling in the moderate category, moderate. And then you need at least 1 of these categories. So we fall into the category 3, discussion of the test interpretation. And then RX management falls also in the moderate risk. So here we have, you need to have two of these columns in at least the same row in order to choose that row of complexity. So here's 1, 2, and 3. So we're going to pick a 99204. It's kind of a no-brainer in this situation. So medical decision-making and time-based both came out as a 99204. An initial visit or a new patient visit for 99204 is $99.86 per the Medicaid max fee schedule. So what are we going to pick? Pretty typically, people say that if you can do time-based, it's more efficient and simpler documentation. And in this case, I think that is what I would suggest going with. It really depends on if you have somebody with a very complex disease process, but something that took you very little time, that might be when you would choose the medical decision-making route so that you could maximize your revenue there. Okay, otherwise, maybe would we want to pick WPQC? Maybe you are a WPQC extraordinaire pharmacy and you have been utilizing this method for a long while. Just a reminder of the fee structure here for WPQC versus the E&M codes. You have $40 follow-ups for WPQC versus $77 for the follow-ups for E&M. So I think that's a consideration if you think you're going to be seeing the patient again. Depends on how you feel about DAPO and how you feel about doing a medical history or exam for the E&M codes, which I'll talk about in a minute. So we think this is really depending on how comfortable you are with the medical billing process versus the DAPO process and how many follow-ups may result. But do remember that you need to establish a usual and customary for all services because these are just the max fees that Medicaid will reimburse, but you do have to say, and preferably you'll charge more than the 85 or the 99 so that you can maximize your revenue to the max fee. So a couple of reminders related to documentation before we move on. So time-based documentation requires a medical history or a physical exam, as does medical decision-making. The medical history is a written piece, but the physical exam can be whatever makes sense for the condition that you are evaluating or the problem that you're dealing with. In this case, it could be just vitals for the hypertension that you're evaluating the stability of. And obviously that needs to be within, your physical exam needs to be within your scope and comfort level. The time-based, you need to include the prep time, the patient time spent with the patient, and the follow-up time. And the documentation can be fairly standard. I spent XYZ minutes on the day of this visit on this patient's care. That this includes time spent reviewing the chart, time with the patient, and time after the visit on documentation. For medical decision-making, you really need to be able to justify your three components of the medical decision-making. You should aim to be concise and then really be using that SOAP note to support the level of E&M service build. There are documentation requirements in the Forward Health Handbook that are listed here that are really important to be aware of. So I'm going to turn it over to Abby to go through a diabetes discharge case. And there you go, Abby.
Awesome. Thanks, Carrie. All right, so let's move on to this case with a patient with diabetes. I want to give you a few minutes to go ahead and review this case, and then we'll come back and talk about the same things that Carrie's talking about, eligibility from both a patient and pharmacy perspective, as well as the different options that we have for billing. So go ahead and review that. Okay, and then on the next slide, we have the program decision criteria. Which we'll actually dig into a little bit more. So let's move on to the next part because it's actually a little bit more of the case, okay. So from the previous slide, you'll remember that the patient has Medicaid and they have UHC as an HMO, which you are contracted with. And then they have just been discharged from the hospital due to diabetes complications. They have non-adherence, they're having some struggles with monitoring and nutrition. And if you remember, they have an A1C of 9.1. They also mention that the hospital providers recommended that a continuous glucose monitor or a CGM would be valuable for them. So you schedule a med checkup for the next day. And during that appointment, you talk about monitoring and nutrition. You identify some gaps in therapy to be addressed. You review all of their medications, and you kind of come up with these plans. So the good news is that you also have a CPA that allows you to generate a prescription for a CGM for this patient. You prepare that as a prescription. Of course, you go through the whole prior authorization process. And then you send a fax to the primary care provider with recommendations based on those gaps in therapy. Okay, so there is a wide variety of ways that we could think about this from a medical billing perspective. So let's walk through each our options. So the case for WPQC. So as we mentioned, they have Forward Health. They they have active HMO coverage with a HMO that you are contracted with. Um, they have diabetes, which is an automatic eligibility criteria for WPQC. So you would be able to get a DAPO approval. And you, they also actually have just experienced a transition of care, which would also make them eligible for WPQC. And so this is similar for WPQC in that they're eligible for it. You can provide it straightforward, just like the previous case. On to the next slide. I wanted to add this, although we're not specifically talking about Medicare medical billing. I just like to mention this because it's a whole other patient population that needs diabetes services. And so just wanted to put this in as a reminder that if you are a pharmacy that has a DSME accreditation, and the patient has active Medicare coverage, there is a vehicle by which you can provide diabetes self-management education to a patient. In addition, we also have some support within the state that we can help pharmacies that want to implement DSMES in your pharmacy. So certainly reach out to us if that's something that would be valuable to you. Okay, so let's move on to medical billing with Medicaid, which is, you know, the hot topic that we are all interested in. So from this perspective, a reminder, this patient has a Medicaid HMO that you're contracted with. You may have noted on the slide that this is actually an established patient as well. So they have been seen in your pharmacy for medical services in the last 3 years. So we have the opportunity to provide an evaluation and management appointment with this patient and bill based on that. So let's talk through that. It can be billed just like the previous one using time-based. So I came up with this, took 29 minutes to provide this service. On the next slide, if you look at it, that automatically puts us at the 99213 level, which has a reimbursement of $54.39. If we look at it from a medical decision-making model perspective, those 3 criteria, as far as complexity goes, this patient has a chronic illness with an exacerbation or progression of some sort. So that puts us at the moderate level. What we are reviewing is just the discharge notes with the A1C. I put that at low. Certainly there could be a situation where you have access to other records or other labs that could bump that up further, but in this case it's low. And then as far as risk goes, because you are identifying gaps in therapy and addressing their prescription management, that criteria is there. I do want to make note here, you know, we generated a prescription for a CGM also. That in and of itself would not meet the criteria for being RX management. Even though in the pharmacy, we dispense CGMs as a prescription, it is considered a device. And so we wouldn't, you know, just generating a prescription, or if you're generating a prescription for an over-the-counter medication based on a collaborative practice agreement or whatnot, that also would not meet the criteria for RX management for this purpose. So just wanted to note that because that's something that had come up. Okay, So based on all of this, we can see that this, using the medical decision-making model, it would put us at a moderate or a 99214 level, which does have the reimbursement of $77, which I don't have on. In addition to that, you would, there is also a medical billing, a CPT code, 95249, that is for patient provided CGMs, meaning we are helping the patient to place their sensor, hook it all up with their phone or the reader. If there's calibration required, if the patient needs training, if they want to try to get their results, all of that is included. And it's essentially just like that training. Many of us are doing this in the pharmacy already and not being reimbursed for it. So this is an opportunity to get reimbursed for that time and that service that we're providing. It can only be billed once per receiver. It can be billed separately or in addition to an E&M code on the same day if it's medically necessary. If it's really two separate services, they can both be billed. So it would be in addition to an E&M code. So how do you decide if you should be billing 99214 based on medical decision-making or time-based? Obviously, you want to choose the one that gets you higher reimbursement. I think Carrie might have mentioned, but I just think this is such a super important point. I just want to say it again. Generally speaking, if you are able to provide the service in a super efficient way, you speak very clearly, the patient understands, they're repeating it back, it's a complex situation, but the patient is understanding it really quickly, that makes sense to do a medical decision making, or you can get reimbursed more using medical decision making versus if you have a situation where you have health literacy concerns, language barriers, you're using a caregiver or interpreter, or they're just having a hard time and you're really needing to repeat things or, spend more time, then a time-based CPT code can be useful. So in this situation, obviously the 99214 will be reimbursed more than the time-based code. Alternatively, we can compare that to doing this as a WPQC CMR. So we have those flat fees of 85 for the initial and 40 for follow-ups versus because this is an established patient, those E&M codes are lower. Obviously, if you are going to be doing, if you know that there's going to be multiple follow-ups, that can determine whether you want to continue doing E&M codes or WPQC follow-ups. And then just remember, in addition to all of this and the considerations that Carrie talked about, we would have that add-on CGM placement code that we could really use in either situation, but something to keep in mind. Truth is, there's really no right way, and it's just going to be different in each situation. Sorry to be the bearer of bad news. Okay, so the third case that we want to talk about is kind of in the lifestyle preventative health world. So I'll just give you a moment here to read this, and then we can talk about the same considerations. So a couple things to highlight from this case is the patient is picking up just 2 medications, presumably for 2 disease states. They are trying to really embrace lifestyle and preventative health. In your pharmacy, you have a diabetes prevention program, which is a service covered by Medicare, but not by Medicaid. You do have 2 pharmacies that are trained as lifestyle coaches. And so they're really comfortable having these types of conversations and helping patients with this. And the patient has Medicaid, but does not have an HMO. So if we look at the program decision criteria summary here, not as many check boxes as in previous cases, right? So let's move on to specifically looking at WPQC. This one, they do not, based on the information we have at least, are not eligible for a WPQC CMR, and we would not be able to get DAPO approval. Now, of course, there are situations we could, a physician could do a referral to us. There could be health literacy issues. There could be multiple providers, which might change whether a CMR would be appropriate for this person. But with the information that we have here, there is not enough information to say that a WPQC CMR would be covered. As far as medical billing goes, there are CPT codes that allow us to provide preventative medicine counseling and risk factor reduction interventions. And so this is to be face to face. It can be around diet. It can be about exercise, alcohol, substance abuse. This is also what is used for like vaccine consultations, above and beyond just administration of vaccines. And so here are the CPT codes 99401 and down. Notably, they are additive. So if you spend 30 minutes, you're using 99401 and 99402 and getting both of those reimbursements. There are not really like limits or specific restrictions around how often you could meet with a patient to discuss these things, but you really just want to make sure that when you're documenting, you are just documenting that the frequency and duration that you're choosing is determined by the patient's medical needs, right? On this last slide, it just kind of talks through that we can use the preventative E&M codes. In this case, it is a new patient. Obviously, once you see them, then they become established patients. And then, of course, on the far right here, I have a brief mention of Medicare as well, because again, like I know that it's not just Medicaid patients that are preventing to your pharmacy for services. So if you have a diabetes prevention program that is enrolled with Medicare to be reimbursed by Medicare, this would be a situation where you could offer them this service if they have active Medicare coverage, which this patient does not. But that would be an opportunity. And again, this is something that we are able to support you with in Wisconsin to implement. So just wanted to highlight lifestyle and preventative med or preventative services, because I know this is an area that a lot of pharmacies are getting into. And there are ways to provide that under the medical billing and the WPQC structure. So then we will hand it over to Michelle to kick off case number 4.
Thanks so much, Abby and Carrie. We're going to kick off case number 4 with a transition of care. But first, before I launch into my cases, I as a practicing pharmacy owner and staff pharmacist, see things we do every day that fit the mold of provider services. And I think this is such a terrific opportunity for community pharmacists to showcase the way we make a difference in patients' lives every day and be compensated for that. So I really feel like this work is so meaningful, and I'm so thankful for PSW and the work that's been done to facilitate our ability to attain provider status. So with that, a case of transition of care, which most community pharmacies are seeing on a daily basis, where a transition of care is happening and a patient is maybe needing a bit of assistance from the local pharmacy. So in this case, the pharmacy receives a call from a patient's family member who lives out of town. JC had been hospitalized for a CHF exacerbation and has diabetes and COPD, and the family would like medications bubble packed following the hospitalization. He has Medicaid, and I'll let you read through the remainder of this case. but the community pharmacy spend some time um, with this patient. So I'll let you take a look at the case as we move through. So next slide. So as you're thinking about how to approach the scenarios around this patient, we've utilized a collaborative practice agreement. We're meeting with a patient. We're evaluating the qualifications he has on the WPQC side. He checks a number of the boxes with that hospitalization in the last 2 weeks, as well as having the Medicaid RX coverage. On the medical billing side, there's an active Medicaid HMO medical coverage in place, as well as the pharmacy has therapeutic substitution CPAs to address any medications that aren't covered. So next slide. So with that, the family schedules an appointment with the caregiver and JC to review the medication packaging options and provide a consult. We look at needs upon discharge and learn that with his CHF exacerbation, getting an appropriate or an accurate weight is really important. So the pharmacy team helps him with that. We also review his inhaler technique and vaccine status to plan those vaccines once his antibiotic course is complete. Additionally, the electronic health record is reviewed, and there's a physician communication looking at a recommendation to consider CGM because the family had concerns around his ability to manage monitoring his blood sugars. So all in all, once the therapeutic substitution is utilized and reviewing of insulin conversions and facilitating inhalers, you've spent 55 minutes with this patient. So on the next slide, we'll take a look at qualifications. So he's definitely qualifying for WPQC as mentioned before. The billing would be through the, getting the PA from the DAPO center, and then being able to bill the initial transition of care with that patient. Next slide. When we look at the medical billing opportunity for this patient, we've spent 45 to 55 minutes with him. Falls into a couple of levels of moderate intensity. It had been reviewed earlier today. When you look at the amount or complexity of the data reviewed, it's probably a little bit lower, but overall would fall into that moderate risk category. Next slide. Or a 99204. And as you look at this, kind of substantiates what we went through from a complexity standpoint as far as problems covered, the CHF, diabetes, and COPD. The amount and complexity of the data reviewed fell into a low category. However, as we're employing RX management, that would take us into a moderate level of care. Next slide. So comparing that to WPQC, you're looking at a WPQC, $85 with an initial meeting and $40 follow-ups versus the E&M code that falls at a $99.86 standpoint for that patient. So on the next slide, we'll talk about that time-based E&M code versus the medical decision-making 99204. The 99204 is the direction that the pharmacy might want to take for billing this situation. Next slide. So in summary, with that case, including the documentation and investigation around this patient, we're able to bill that 99204 for 55 minutes of care. And then looking at future opportunities with this patient, he's picking up packs every 2 weeks. We're administering vaccine, and we have the potential to follow up on those CGM services. So a very common patient that I think a number of us are taking care of in our pharmacies, day in, day out, and has a number of different opportunities there for his care. On the next slide, we're going to go through a workflow whereby a patient is searching for where we have a smoking cessation opportunity. Oftentimes, we have patients walking into our community pharmacies where they've been at a clinic and presented to a nurse and a physician or provider who are all looking at the patient, asking them about care related to their nicotine addiction. And sometimes once they hit the pharmacy and they've heard that question again, they're ready to make a change, and we have the ability to provide the medications or nicotine replacement to help that happen. So in our pharmacy, we've got a collaborative practice agreement in place to offer that therapy. And in this case, we've got a patient who's on their second antibiotic in a month. The pharmacist counsels them on smoking cessation, and they're ready to try a quit attempt. So and with this patient, they have Wisconsin Medicaid and UHC, and the pharmacist is a contracted provider. So the pharmacy team initiates the smoking cessation review, patient assessment, review of assessment, and Epic Care link to verify that there aren't any contraindications to therapy, and the patient agrees to smoking cessation. And in the course of this care, the pharmacist has reviewed the EHR and discussed options with the patient, and ultimately bupropion was initiated. So in this case, the pharmacist is additionally providing initial smoking cessation counseling and initiating that medication. So all in all, they've spent about almost 40 minutes in this care activity. In this case, this patient does have Medicaid prescription coverage. However, they don't have the qualifiers immediately necessary for a DAPO approval of a prior authorization. However, on the medical billing side, we do have a contract with their Medicaid HMO. We've got a CPA in place for the service that we've utilized, and the patient has active coverage. So that's a direction that we can take. So in the next slide, we'll illustrate that there was just insufficient information to collect that WPQC PA. So we're going to move on to the medical evaluation of this patient. And another situation where there are two levels of moderate, or two opportunities around moderate medical decision making, where the complexity of the problem addressed, as well as the use of RX management, puts us in those moderate categories. And then after reviewing the case, we've identified the patient has moderate complexity with chronic bronchitis and nicotine dependence. The review of their EHR and medication initiation also puts us in a moderate level of complexity. And then the RX medication management also puts us at a moderate, so supporting that 99204 for this patient. So as we look at the medical decision making versus the time base, the complexity puts us at a 99204 for this patient, where we would be able to bill for the 9986. And that's the direction we would go for that patient. In the world of medical billing, so we've got the prescription drug management for that chronic condition. And then in other cases whereby the patient presented for smoking and tobacco use cessation counseling, and we've spent some time with them. You can see the time and minute and reimbursement available for those patients, utilizing a modifier if the smoking cessation is a distinct service. And recently, pharmacists were added as providers of these tobacco cessation services. So I encourage you to take a look at that Forward Health Handbook topic to review the specifics related to billing of this service. Next slide. And in a week, we want to follow up with that patient and check in with them. We find out that they're feeling better, but still struggling a little bit. The pharmacist provides some suggestions. And with that, we've got a telehealth consultation that we've provided the patient. You can see that the time increments that those can be billed in, and Forward Health has another handbook topic around telehealth service offering. And I'd encourage you to take a look at those opportunities as well. So as a reminder, the telehealth evaluation and management service by a physician or other qualified healthcare professional needs to be provided within certain time frames. So it's really important that you take a look at those requirements around telehealth, that they're not originating from a service related to an E&M service provided within the previous 7 days, or that the patient has a E&M service or procedure scheduled within the next 24 hours. So just thinking about how that flows through for the patient. And that's where that electronic health record awareness of when they're seeing physicians and what your team is doing at your pharmacy becomes important. Next slide. So in summary, for this smoking cessation situation, we do have the ability to bill with documentation, medication, and investigation for that 99204, and then potentially utilize telehealth in the follow-ups provided to provide further support to that patient. And now we're going to review a little bit around resources. DHS has a number of recommended reviews and trainings for your team out on the Forward Health website. I really encourage you to work through those and review those with your teams as appropriate. Next slide. And then in the world of coding and documentation standards, there are a number of resources supporting our work. Coding tools are provided as links and references in this module. Recently, I've gotten a subscription to something called Codify. So there's just a number of background resources for substantiating and helping your team understand the process around coding, documentation, and billing of these services. Next slide. And we won't forget how much work the Pharmacy Society of Wisconsin staff has put in for us around Wisconsin pharmacist provider status. There are a number of resources out there. Encourage you to sign up for the provider pulse that PSW is putting forth via email. In addition, there's a number of resources available on the website. So really encourage you to take a look at those, and they're getting updated very frequently. So take a look at what we've got there for our members. And there's also through the PSW, a pharmacist certificate program for medical billing. Each of us on providing this slide presentation spent a number of times looking at medical billing 101 and really wrapping our heads around the differences in the world of medical billing. And I think that's just a really helpful resource that was provided by Julie Bartel and her team. And just really a number of great resources providing a good foundation around provider service that you can employ in your pharmacy really practically. And Abby and I are part of the CPESN group in Wisconsin, the Community Pharmacy Enhanced Services Network. We're a network of about 90 pharmacies, community pharmacies around the state. And our group has access to a special purpose network called CPSN Med Bill Supports. And though this group comes with an additional fee for CPSN members, there's really turnkey resources available to get community pharmacies up and ready to provide services with workflows and billing support. So something to certainly reach out to Abby or I on, and we can point you in to get connected with that. So with that, we'll go through a couple of learning assessments. So which statement is true regarding the primary difference between coverage of services by Wisconsin Medicaid through the prescription benefit WPQC versus the medical benefit? I'll have you take a look at the answers. WPQC CMRA services are billed to the prescription benefit. CPAs are required to bill for CMRA services. Wisconsin Medicaid CMRA services do not require the use of CPT codes, or pharmacy technicians can only support services billed to Wisconsin Medicaid medical benefits, not WPQC CMRA services. And the correct answer for learning assessment is selection A. And the next learning assessment question, the following services could be billed by a pharmacist to the Wisconsin Medicaid medical benefit without having a collaborative practice agreement or CPA in place with a physician. Let's just take a couple of minutes to read through these. And the correct answer for this learning assessment question would be letter D, A, and C. And the final learning assessment question, a patient is discharged from the hospital after being admitted for diabetes complications. What type of service could a pharmacist provider bill for if meeting for 1 hour with this patient to comprehensively review their medications in the clinic or community pharmacy? WPQC CMRA, an office visit based upon medical decision-making or time, either or neither. And the correct answer for this one would be letter C. Either situation could be billed. And the last thing, I think I previously mentioned this, but you can sign up for Pulse on Provider Status newsletter via the link on this slide. It's provided in the course documents, and we really encourage you to reach out and to any of us and look for information regarding medical billing. If you get stuck, we're here to help support you, and appreciate you taking the time to listen to us today.